Welcome to our program on elevating excellence in hormone receptor positive, HER2 negative, early and metastatic breast cancer care. We're going to focus on success strategies for community oncology practices. My name is Sarah Tellini, and I'm a breast medical oncologist at Dana-Farber Cancer Institute and chief of our division of breast oncology here. And today I'm joined by my very esteemed colleague, Dr. Gregory Vidal, who is director of clinical research at the Lee S. Schwartzberg Research Center and chair of breast oncology at West Cancer Center and Research Institute, also associate professor at the University of Tennessee Health Sciences Center in Memphis. So thank you so much for joining us today, Gregory.
Thank you.
We'd also like to thank PeerView and breastcancer.org for providing this educational session, and thank Lilly for providing the educational grant for this program. We'd like you to please engage with us today, so do look out for polling questions during the workshop and submit your questions to us via the chat window, and we'll answer them throughout the workshop. You can visit the URL as shown here and view the slides and practice aids and download them after the event. So our goals for today are to equip you all with knowledge about the efficacy, safety, and evolving clinical roles of the latest treatment options for patients who have hormone receptor positive, HER2 negative breast cancer. We're also hoping to enhance your skills in formulating individualized treatment plans for patients who have hormone receptor positive, early and metastatic breast cancer, and improve abilities to implement team-based strategies to anticipate, detect, and manage treatment-related adverse events in patients who have hormone receptor positive breast cancer who are receiving systemic therapies, and really also hope to maximize adherence and persistence. We'd also like to thank breastcancer.org, who is our patient advocacy partner in this program. Their mission is to help people make sense of the complex medical and personal information about breast cancer health and breast cancer so they can make the best decisions for their lives. To help the global community of patients and care partners, breastcancer.org offers trusted educational content, community conversations, and other resources. So please access and use the supplemental downloadable resources made available as part of this program. So to start us off, we're going to think about how we actually assess risk in the treatment of patients who have hormone receptor positive, HER2 negative early breast cancer. So when we're thinking about early stage breast cancer patients and trying to make decisions about use of systemic therapies, it's really important that we do understand risks so that we can figure out what the appropriate treatment regimens would be. One of the tools that I think has become really important in patients who have early stage hormone receptor positive breast cancer has been the incorporation of genomic assays. We know that these assays can help us understand two big components. One is, what is the risk of recurrence from this cancer? And is this cancer going to benefit from the use of systemic chemotherapy? And so we now have very robust, prospective, validated data for the use of the Oncotype DX assay, which has taught us that if someone has a high recurrence score, they have a high risk of recurrence, but that they also benefit from chemotherapy. Whereas patients who have low Oncotype scores, for example, these are patients who have lower risk of recurrence and are patients who are not generally benefiting from chemotherapy. And so this has really become a very important tool for us to figure out who needs what treatment. We have data that extends not just to node-negative hormone receptor positive patients, for example, from TAILOR-X, but then we also have data from our exponder within the node-positive population, where we've also learned how Oncotype can help guide treatment recommendations, though I will say this has become a little bit complex based on menopausal status, where it seems pretty clear-cut in a postmenopausal patient that if they have an Oncotype score that's greater than 25, that they have high risk of recurrence and that chemotherapy is going to provide benefit. And this is also true in the premenopausal patients. But once you get to the patients who are under 25, again, it's clear in the postmenopausal patients, they don't need chemotherapy. But where it gets a little murkier is in the premenopausal patients under 25, where there does seem to be some benefit from chemotherapy in this population. And in my mind, it's not so clear if this is due to the cytotoxic effects of chemotherapy or potentially suppression of ovarian function in premenopausal patients, which may be conferring benefit. And so we're going to need more data here, and there is actually a prospective ongoing study called the OFFSET trial, which will help us understand this in a prospective manner. But nonetheless, I think from thinking about these assays, they are critical because it helps us understand risk, which, as you're going to hear as we go through our discussions today, is actually really important when making decisions. And we are going to be incorporating use of genomic assays to help us understand if that risk is high enough to make some treatment decisions. And so again, it helps with chemotherapy decisions, but there is also now data to suggest we may want to think about it, particularly in borderline risk patients, where we're deciding about use of CDK4/6 inhibition as well. And so I think this is going to be an important tool that we're going to be continuing to utilize.
All right, so we'll discuss evidence for adjuvant CDK4/6 inhibitors in reducing risk of recurrence. So Monarch E design, there were two cohorts. The first cohort was patients with a lot of lymph nodes, 4 or greater. If you had 1 to 3 lymph nodes, you had needed other high-risk features like grade and tumor size. And then there was a second cohort that utilized Ki-67 greater than 20% and grade and size of tumor as a category, a criteria for selecting patients. And those patients were randomized to 2 years of abemaciclib with endocrine therapy versus endocrine therapy alone. Importantly, tamoxifen was an option for patients, but most patients actually had ovarian suppression if you're premenopausal with an aromatase inhibitor. What we see with 5 years follow-up, and importantly, after 24 months, we saw early separation of the curve, which led to statistical significance very early, but the curves continue to separate. And at 5 years, we see a delta of 7.6% between the patients who got abemaciclib versus not, a significant hazard ratio of 0.68 and the p-value of 0.001, 32% reduction in risk. And as I mentioned before, curves continue to separate. For distant recurrence-free survival in the intent to treat population, very similar trajectory. Curves separated at 2 years and continue to separate after 5 years follow-up, hazard ratio of 0.675, 32.5% risk reduction. And this now is a standard for patients that meets criteria for enrollment in this study, as we talked about before. Overall survival was not significant, and at 5 years, there is minimal distance between those curves at this point, and we're still waiting for some data regarding overall survival, maybe long-term, maybe in the 20 years period. For estrogen-positive tumors, as we know, getting overall survival usually requires sort of more longer follow-up. Here we look at fewer patients with metastatic disease in the abemaciclib arm, just looking at overall survival and what are the characteristics of the patients from a perspective of who's alive, death through breast cancer or death not related to breast cancer. Again, just in summary, in the ITT patients on the left versus overall survival at interim analysis 2 and interim analysis 3, we see the patients who are being, or the cohort who got abemaciclib has less events, less death due to breast cancer, less death related, or unrelated to breast cancer, and more patients are alive with metastatic disease when you utilized abemaciclib. Toxicity is no different than we saw when we utilized this drug in the metastatic setting. Diarrhea was a primary adverse events, with about 84% of patients getting any grade diarrhea, which was much lower than we saw in the endocrine therapy group. Arthralgia was also seen here. Importantly, and a little bit surprising, at least for me when I first saw the data, I think we first saw it with the palbociclib, is that arthralgia was improved with patients who got abemaciclib. So somehow adding abemaciclib to the endocrine therapy result in less arthralgia complaints from patients, and it may be because of a dominance of other side effects, but certainly that was surprising to me, and we see hematologic toxicities and also GI toxicities being dominant. We also have to make mention that VTE was slightly higher although low, but slightly higher in the patients who got abemaciclib, and we saw some of that data in the metastatic setting. And ILD was also higher for the patients who got abemaciclib. In terms of dose modification, 42.5% required dose modification on study. Most frequently in the first few months, 30% discontinued abemaciclib earlier, 18.5% due to adverse events, and most within the first 6 months of treatment. Over half did not have a prior dose reduction. This is very, very important when we're thinking of putting patients on study. It's important to have a discussion with patients about the adverse events, important to give prophylactic medications, teach your patients about what to expect, when to utilize it, because what we're seeing here is some patients, after having adverse events, don't even want to try the drug and get further reduction for a drug that maybe certainly have that clinical benefit. What's important here also is dose modification. So this table or data is showing us that if we decided to dose reduce patients, those patients have similar outcome. So you see relative dose intensity here, 0 to 66%, 66 to 93%, and 93% and above. If a patient is having issues with adverse events and you dose reduce, their outcomes end up being the same. So 4 years IDFS is generally consistent, 87.1 versus 86 versus 83% for the lowest relative dose intensity group. So if you have to dose modify, please do. Generally for me, most of my patients, I dose reduce there. I can maintain them at 100, which I probably think is the best dose in the early setting. But for most of my patients, I do start at 150. We have studies which will show later on that's looking at whether or not we could take a strategy of starting low and titrating up based on tolerability and whether or not the outcome are equivalent. Oh, and there it is, the TRADE study. It's a phase 2 dose escalation study where patients who meeting criteria for abemaciclib in the adjuvant setting start at 50, dose increase to 100 milligrams at day 15 to day 28, and then eventually 250 milligrams based on tolerability.
I'd love to get your thoughts on monarchy. I will say that when we first saw the data with abemaciclib, it was very early, right? With under 2 years of follow-up, but now we have 5 years of follow-up, and what we've continued to see is further separation of the curves. I think everyone was really nervous at the beginning that, once you stopped the abemaciclib after those 2 years, that we weren't going to see the continued benefit. But in fact, it seems as if there's some carryover effect, that there continues to be benefit that is, we're seeing even greater benefits with longer follow-up. So I'm curious, in your practice, now that you've seen the longer follow-up data with 5 years, are you using abemaciclib for everyone who meets monarchy eligibility? Do you ever go outside the monarchy eligibility? Because it is fairly stringent, I think, with 1 to 3 positive nodes needing to be over 5 centimeters or be high grade. And do you incorporate genomic assays or Ki-67 into that decision making at all, which isn't part of the current label for utilization of abema?
So very good question. Regarding the Ki-67, it was a criteria in one of the cohorts, and so yes, I do use that. In fact, the first approval limited to Ki-67. I tend to follow, for most part, the criteria for monarchy approval. Every now and then, if there's a patient that I'm concerned about who have, for example, T4N0 was an exclusion in monarchy because they didn't have node positivity. I think that's a high risk patient. So prior to ribociclib coming on board, I would offer those patients abemaciclib based on the fact that I know that's a high risk patient population. So for most part, I do follow the criteria. I offer it to almost every patient who meets criteria for monarchy. We have discussions about side effects, discussion about adding another drug and how long they have to take it. I must also say, it's important to have that conversation with your patient at the beginning when you first starting treatment, and let them be aware that there is potential two drugs coming on. Because what I've found is if you wait in the adjuvant setting, especially for patients who've gone through chemotherapy and now they're expecting to be on one drug and you're like, well, we could add two, I do get some pushback. So framing it before they start all of this at least sets an expectation. Do you find those issues also, Sarah?
I think you are spot on. I mean, I think it's a long journey for people who are diagnosed with a high risk hormone receptor positive disease, some of whom may need chemotherapy. And so by the time they get through chemo, radiation, initiating endocrine therapy, and then you tell them, hey, you need to take this other pill for another 2 years, they're like, wait, you didn't say that before. Then they get. I think it throws them off, and I think it does create a lot of stress. And so I definitely think it's much easier for people to kind of see the whole picture. And then I think I kind of try to reintroduce each step and remind them as we go, because it is also a lot of information that we throw at people at one time. So I think you're exactly right. It is important to make sure that they're prepared, early on in the journey through things. Can I ask you another question? So this is something I often struggle with a little bit in my head is that, for most young women, the premenopausal patients, we know that they do have biologically high risk disease, generally speaking, higher risk than postmenopausal patients often. And so we're also thinking about using ovarian suppression and AI in most patients who have high risk hormone receptor positive disease that are premenopausal rather than using tamoxifen. So I'm curious, if someone doesn't tolerate the AI and you're going to switch them to tamoxifen while they're on abemaciclib, how worried are you about risk of thromboembolic events? You reviewed the fact that abema is associated with a higher risk of VTE. We do know that risk is higher, and probably around 4% or so if giving tamoxifen with abemaciclib. Does it bother you, or do you feel comfortable with the combination?
I do feel comfortable with the combination. That means like 96% of patients don't have issues with that. And I also take a careful history of patients in terms of whether or not they have other risk factors for VTE development, and would be more cautious in that patient population. I probably have one patient, I think, right now on tamoxifen, and because she just totally refused to have ovarian suppression, and she had high risk disease. So my preference would be ovarian suppression with AI. I will consider tamoxifen, and I will follow that patient very closely, but I would feel comfortable giving those patients tamoxifen. What about you?
Yeah, no, I do too. I will say this has come up for me actually. I had a male patient who had 21 positive lymph nodes after an axillary dissection. And so I was really debating what to give him. And in males, it's not clear if, giving a GnRH agonist with an AI is superior to, for example, tamoxifen. It's a little different in that situation. And it's obviously hard to give a male a GnRH agonist. It's, a lot of toxicity for them. So I thought, well, could I give him tamoxifen in abema? He was an older gentleman in his 70s. And so I actually chatted with one of our hematologists who happened to have been on the Monarchy thromboembolic committee. And so she told me to use a prophylactic dose of DOAC in that case, because she felt
What was that dose?
I'm sorry?
Prophylactic dose. What was the
prophylactic dose? It was like 2.5.
2.5.
Yeah.
Okay, interesting.
And so that's what we did, just because he was older and a male. And so I think, again, it's just something I think we like to think about. If they have risk, then something to certainly consider. But I would agree, it's nice that you can use tamoxifen in case you need to. Whereas we're going to switch gears and talk about Natalie. And, unfortunately with ribociclib, you cannot use tamoxifen concurrently because both of those drugs do prolong QTC. So just something to keep in mind. But we do have another CDK4/6 inhibitor that we can use, which again is really important to have options for patients. And, as Gregory alluded to, this study has a broader eligibility than Monarchy. So it included not just high-risk hormone receptor positive patients, but also what I would think of as intermediate risk patients. So the trial was specifically for patients who could have had any nodal involvement. So if you had a node positive or one or many nodes positive, you were eligible. You didn't need an additional high-risk feature like we needed on monarchy. Or you could actually have a node negative hormone receptor positive cancer as long as it was either greater than 5 centimeters, or if it was between 2 to 5 centimeters and node negative, then you needed an additional high risk feature. So you needed to either be grade 2 with a high genomic assay or high Ki67, or be grade 3. So you have to think for the node negative patients, again, that you either have to be really big or you have to be between 2 to 5 centimeters and have an additional high risk feature. Otherwise, if you've got a node, you are eligible. And then patients were randomized to get an aromatase inhibitor with or without ribociclib. And the ribociclib here, just to note, was given for 3 years. So again, remember the duration here is different than in monarchy, where abema was for 2 years. And the other little tricky thing to remember is that the dose of ribociclib here is 400 milligrams, 3 weeks on, 1 week off, which is lower than the dose that we use in the metastatic setting, which is that 600 milligram dose. So here they did use a lower dose because they were giving it for a prolonged period of time, and they were really hoping that it would lead to less toxicity and allow patients to be able to stay on drug for the 3-year duration. So what we now have is 4-year follow-up from this study. And so the 4-year invasive disease-free survival with the aromatase inhibitor and ribociclib was statistically significantly better than it was with the AI alone. And you see that the absolute difference between the two arms was about 5%. So in essence, you're seeing about a 30% reduction in events by adding the 3 years of ribociclib. And interestingly, this benefit was pretty similar between those patients who had stage 2 or 3 disease. You can see the hazard ratios are around 0.7 in both the stage 2 and 3 patients. So, again, saying that the benefit is seen in both populations. And I was really curious to see these data because this is the first time we've seen use of CDK4/6 inhibitors in node negative patients. And here you can see that the absolute benefit for the node negative is really the same as node positive, but I do want to make a big caveat here, is that the number of patients that had node negative disease in NATALY is small. So it's only about 12% of the trial. And so you have to realize that the confidence intervals around this are really large. So if you look at that hazard ratio of 0.66, you can see that confidence interval really ranges from around 0.4 to above 1. So, it's saying that we don't really have a lot of precision around that particular risk reduction estimate. And so I think I would just keep that in the back of your mind, that I don't know that their absolute benefit is really the same in node negative and node positive, because again, it's not quite as precise given numbers. But importantly, most of the events that we're seeing were distant events. So that's similar to what we saw in monarchy. Most of the events were distant events in that trial as well. So that's saying that this is a big deal, because reducing distant events is reducing patients from getting metastatic breast cancer. And while you're seeing survival is not different, we also know that once patients develop metastatic disease, fortunately, these women are usually living for several years. And so we're not likely to see impact on OS for a really long time, because again, these patients thankfully are living for quite a while once they recur. And so I'm not surprised that we're not seeing OS at this time. I think in ER positive breast cancer, that's going to take a really long time to be able to show survival impact. And with regards to toxicity, I think we're familiar with toxicity from ribociclib that we've seen in the metastatic setting, where neutropenia certainly is something to be mindful of. However, rates of neutropenia are lower at the 400 milligram dose compared to what we saw in the metastatic setting at the 600 milligram dose. Here you see grade 3/4 neutropenia is around 40% instead of around closer to 60%, which is what we'd see in the metastatic setting. I think some important things to remember with ribo, though, are that you do get QTC prolongation. It's less at the 400 milligram dose than what we saw at the 600 milligram dose, but it does require monitoring. So we do like to get EKGs every 2 weeks for the first 3 visits when patients are started on ribociclib, to make sure we're not seeing that prolongation of QTC. And then the other thing is the elevation of liver enzymes. That is something that can occur with ribociclib. And you can see high-grade LFT elevations, and that was actually the most common adverse event that led to discontinuation in this trial. And sometimes I do find it takes a little bit of time off of ribociclib for those LFTs to come down. So sometimes you just got to wait for them to come down. And again, it can sometimes take many, many weeks. And so you just have to monitor for that. But just like we saw in monarchy, dose modification can be helpful with dealing with some side effects. For example, with ribociclib, neutropenia is very sensitive to dose modification. And you can see that when patients were dose modified, the benefits that were seen with ribociclib really look the same as the patients who weren't experiencing dose reduction. So I think that's important. And this is a common question that I get from patients who get really anxious when, understandably about dose modifying, where they're worried that maybe we're going to see less benefit from the drug. And some patients get really reluctant to tell you about their side effects because I think they get worried that we're going to dose reduce them. But I think these data are so important for patients because it really tells us that it's okay to dose modify, and we're seeing similar benefits. But I think given this, Gregory, I think it does bring up this very challenging question. In fact, I will say in our staff meeting this morning, we had a debate about this in our own group about how to think about which patients get which CDK4/6 inhibitor, because now you've got choice, right? So if a patient walks in the door and they're eligible for both monarchy and NATALEE, how do you decide which drug to give them? Because I think that is a tricky question. I don't know, how have you been thinking about this?
So, yeah. So I try to simplify my practice based on evidence. And for now, my practice is mainly because I have longer experience personally with abemaciclib in that population, but also we have longer follow-up with Monarch E data. Any patient who meet criteria for Monarch E gets abema, the rest gets ribo. That's how I do it. Unless there are obvious contraindications for them. One of the things I don't think we talk about enough, especially practicing in the community setting, is drug-drug interactions with ribociclib. That is so very important, especially for the audience out there. There are lots of drug-drug interactions with abemaciclib. You do have a lot of patients who are getting their care outside your institution, their primary care, starting new diabetes medicines, starting new depression medicines, starting them on new antibiotics. And those are the things you have to think about that and have those conversations with patients. But even before you start it, doing that interaction. So if we do have a patient that meets both criteria and there's an issue with drug, they get abemaciclib. So that's how I try to simplify myself. What about you? What do you do?
I like that. I will say that was kind of the conclusion that came out of our staff meeting too today, is that I think we also wanted to keep it simple, that I think people felt a little more comfortable with use of abema in the monarchy population, as you pointed out, because of the longer follow-up that was in that trial. And so I think that was our group's preference. And then if people fell outside of monarchy eligibility and met NATALEE eligibility, then we were comfortable utilizing ribociclib. Though I will say there was a little bit of debate about, should we be using ribo in all of the NATALEE eligible node negative patients? Is risk high enough to warrant utilization? And, I think I find that tricky because, like, someone brought up a case, well, what if someone has a 2.2 centimeter cancer that's grade 2 and high Ki67, not someone on kind of the borderline in terms of risk that's node negative. And I think that's where I tend to debate a little bit about whether or not I need to prescribe or not. I don't know if you have a clear delineation in the node negatives.
I don't have a clear delineation, and the people on the board, I have a conversation with the patient. I say, this is the data, this is how long you have to be on it, because there are some patients, regardless of what it is, give me everything. It doesn't matter, give it to me. And there are patients who have fall lymph node, and they're like, why are you adding on another drug? Well, because you have high risk. So there are different patients. I would say patients on the border have a conversation. Patients who I think are more higher risk, more true intermediate risk, I offer it to them. I try to offer it to everybody, but we have a conversation when they're on the border. I do have a question for you in regards to being able to, are you having any issues getting those drugs approved for your patients? because we've had issues in the community, and it turns out you just have to be really clear about how the patient meets criteria. It's about your coding and make sure it's coded appropriately, because I started getting a lot of denials, and I wrote the company them myself, and I'm like, you need to take care of this. And so they sent somebody to us, and they're like, you need to code this better. Are you having any issues?
I will say I don't think we've had issues with getting denials so much as just the process. I think just it's a generalized process with oral, medications where, in our institution, it takes a lot of work. You send a prescription, it needs to see if it needs prior authorization. If it needs prior authorization, we have a team of people who help you with that. And then if it needs to go to a specialty pharmacy, then you need to arrange for shipment. And so then, the nurse needs to let the patient know to arrange for the shipment. And it's just so many steps. And then if you dose reduce, then you have got to write a new prescription and go through this process again. And so I will say that's, to us, it's a lot of burden on staff at our institution. We also have pharmacists in place who do a check-in with the patient after they've been started on any oral, medication. And so it's just a lot of people that are involved in this kind of process. And now that there's so many patients that are eligible for these drugs, as the criteria have really enlarged, I do think this is going to be a little bit challenging on our practices, because it takes a lot of work on the back end to get oral medications. And then it's a lot of monitoring, right? A lot more monitoring than just giving an AI. You are seeing these patients, generally every 2 weeks for the first 2 months. I don't know, do you actually see them physically in clinic, or how do you guys do that follow-up part of this?
Yeah, so we see every patient. So I have my APP sort of do the 2 weeks follow up, but after you've seen them for like 2 months, you can stretch it out if those patients are doing well. The EKG was for ribociclib was the part that had the greatest issues for me, but with the cardiomobile, that has revolutionized my practice. So we do see those patients. From a pharmacy perspective at our institution, we have pharmacy navigators who sort of follow the prescription. If it needs to go to an outside specialty pharmacy, sort of follow this prescription with the patients. What I find though is, at least at our institutions, if there is a large copay, our pharmacy will do the work to find foundation dollars to help our patients. Sometimes that doesn't happen when the prescription leaves our institution. And so that becomes an issue with our patients. So I see you shaking your head. I suspect that's not.
Actually, we made a policy that patients, we have to send these kind of prescriptions to our own pharmacy as a first step because of the tracking, just as you said, because if I send it to like CVS or something, like some other pharmacy that's not internal, then we lose the ability to track it and make sure that we know what the copay is and that we can follow and see if we can provide assistance. So I think you're right. It does take tracking to make sure everything happens okay. So, I mean, it all works out, and it's obviously very critical for patients, but it's good to have a system in place. So next we'll turn and put this into perspective with the case. So this is a 62-year-old woman who had undergone a mammogram and was found to have a 3.5 centimeter mass with a suspicious axillary lymph node that was seen. So her breast was biopsied and it came back as a high-grade invasive ductal carcinoma that was hormone receptor positive and HER2 negative. And the lymph node was biopsied and did have cells consistent with her original breast cancer. Because she had a node positive cancer, she did undergo staging scans, which did not reveal any distant disease, and her germline genetic testing was negative. She proceeded to surgery and had a mastectomy and an axillary node dissection and was found to have a 3 centimeter high-grade cancer with 1 positive node out of 3. She did have an Oncotype DX score that was sent, and it came back at 21. So she ended up coming back after surgery to figure out what to do next. So given that she had an intermediate oncotype, it was decided she didn't need chemotherapy. But then the discussion came up about what the optimal treatment would be for her endocrine-based treatment. And so while maybe an AI would make sense, maybe Gregor, I'll ask you, do you think you would give a CDK4/6 inhibitor? And if so, which one would you use?
Yes, I would offer a CDK4/6 inhibitor. She has a grade 3 disease. She has lymph node positive, even if her oncotype was 21. And I would, because she does meet ABEMA, Monarch EE, my practice would be to offer her abemaciclib, advantage there being 2 years longer follow-up data for this patient.
What if we twisted it and we made it grade 2 so that she fell outside of monarchy eligibility? How would you then think about her?
So then she would fall in sort of the intermediate risk. And then we would think of ribociclib as an option for her, and keeping in mind 3 years now, not 2 years. But I would definitely offer her CDK4/6 inhibitor.
Yeah, no, I totally agree. I would do the same thing. And I think CDK4/6 inhibition makes sense. And so maybe I'll pass it over to you and we'll switch gears and we'll talk about the metastatic setting and how we're thinking about CDK4/6 inhibitors in that space.
So we've had CDK4/6 inhibitors in the clinic for some time now. I think 2016 is when palbociclib first got introduced. Based on Paloma 1, Paloma 2 data, we see the data set here. Importantly, hazard ratio that's highlighted there is right about the same, about 0.5 for all three drugs in the early setting with endocrine therapy partners. And also we have data with fulvestrant. The overall survival is a little bit different, and we'll talk about that later for some of these drugs. But overall, from a PFS perspective, very similar outcomes. Here we see monolith first line with ribociclib, and we talked about this. This overall survival, we saw that being significant with a hazard ratio of 0.76, suggesting that patients with AI ribociclib are living longer than what we have data with fulvestrant. The overall survival is a little bit different, and we'll talk about that later for some of these drugs. But overall, from a PFS perspective, very similar outcomes. Here we see monolith first line with ribociclib. 2 data we see
CDK4/6 inhibition makes sense. And so maybe I'll pass it over to you and we'll switch gears and we'll talk about the metastatic setting and how we're thinking about CDK4/6 inhibitors in that space.
So we've had CDK4/6 inhibitors in the clinic for some time now. I think 2016 is when palbociclib first got introduced. Based on Paloma 1, Paloma 2 data, we see the data set here. Importantly, hazard ratio that's highlighted there is right about the same, about 0.5 for all three drugs in the early setting with endocrine therapy partners. And also we have data with fulvestrant. The overall survival is a little bit different, and we'll talk about that later for some of these drugs. But overall, from a PFS perspective, very similar outcomes. Here we see monolith first line with ribociclib, and we talked about this. This overall survival, we saw that being significant with a hazard ratio of 0.76, suggesting that patients with AI ribociclib are living longer than what we would have normally done, which was standard of care anti-estrogen therapy only. Paloma 2 first line with overall survival, we did not see statistical significance. Ad hoc analysis suggests that maybe there's a population for which there would be benefit, but overall, again, smaller studies, really not powered as much for overall survival, but we didn't see overall survival with the use of palbociclib. Monarch 3, overall survival. And again, I was surprised by this with the use of a aromatase inhibitor and a palbociclib, because it's been trending in the interim analysis like we're going to see overall survival. The delta between the placebo arm and the abemaciclib arm was very similar, slightly higher than what we saw with ribociclib, but we didn't fully see. I had a conversation with the statistician, and they think it's just a statistical dilemma, mainly because of power. But again, I still think there's some clinical benefit from an overall survival perspective for the use of abemaciclib in that population. Subgroup analysis for visceral disease, abemaciclib, and most of the CDK4/6 inhibitors actually have very good activity in sort of high-risk metastatic patients, but abemaciclib particularly showing visceral disease here show a significant delta between those who got abema versus not. Comparing Monarch 3 and Mona Lisa from an overall survival perspective. So we see here for the Monarch 3, final overall survival, the interim analysis versus Mona Lisa. And as I said before, this has been trending. We would just go down to the hazard ratio 0.84, 0.76, 0.76, but you can see the p-values not being statistically significant. Overall, Mona Lisa did get statistical overall survival, but again, I would argue that there is some clinical benefit, and it may be a statistical phenomenon. Fulvestrant and everolimus remains an option for treatment for our patients. This drug got approval pre-CDK4/6, pre most of the targeted therapy, so we don't have sort of randomized data in that current setting, but there was some retrospective analysis that suggests that yes, we do have some activity for the use of everolimus, particularly in the patients who don't have targeted therapeutic approaches. So what about second line CDK4/6 post first line? We have data from Maintain, which was a ribociclib post first line, PACE, which was palbociclib after palbociclib, and Palmera also palbociclib after palbociclib strategy. Maintain showed clinical statistical significance, and I think it's probably because we had not only a change in the CDK4/6, we had a change for most part in the anti-estrogen therapy. So if I am taking a CDK4/6 after CDK4/6 approach, I would definitely do a change in both the anti-estrogen and the CDK4/6 strategy. And I'm very interested in what Dr. Tolaney's approach to that. Post-Monarch, which we saw at ASCO, also demonstrated that the use of abemaciclib and fulvestrant in the second line after previous CDK4/6, most of those patients, again, had a switch in both CDK4/6 and abemaciclib and anti-estrogen therapy. And what we saw is statistically significant improvement in PFS. EMBER-3, so at San Antonio, was looking at what do we do when we combine an oral SERD, which hasn't hit the market yet, but some of us have had it in trials, with a CDK4/6 inhibitor, this time abemaciclib. And also there was a comparison of oral SERD with standard of care anti-estrogen therapy, which is the data we're seeing here. We saw statistically significance in the patients with ESR1 mutation, which is where we have elacestrant approved currently. So we know oral SERDs are effective in ESR1 mutant population. Unfortunately, in the intent to treat population, we didn't see statistically significance, although the curves separated. EMBER-3 further showed the comparison between imlunestrant and abemaciclib, asking the question, if we add a CDK4/6 inhibitor to imlunestrant, this oral SERD, is it better than single agent imlunestrant? And the answer is, based on this, yes. Keep in mind, there was a population of patients on this study, maybe about 40%, I think, who didn't have prior CDK4/6. Even if this was in the second line setting, 60% of patients approximately had a first line CDK4/6, and most of that was palbociclib, and there was about 20% with ribo, and a very small amount with previous abemaciclib.
Can I ask you about, if we go back to like a first line patient, who, let's say that's a de novo patient with metastatic ER-positive breast cancer, how are you figuring out which CDK4/6 inhibitor to give them in the upfront setting? You know, you very nicely reviewed the nuanced data for overall survival, suggesting that currently in the first line setting, we only have technically OS benefit with ribociclib, though as you noted, the data with abemaciclib is very clinically relevant and looks very similar to what we saw with Mona Lisa 2. So how do you pick which CDK to give someone up front?
So it depends on the patient. So an older patient for whom quality of life, symptom burden becomes a question, patient lives far. Overall, I think palbociclib is the best tolerated of all of these. And so for those patients, I tend to give palbociclib, although I don't do it as much. But I think in my institution, we've been an abemaciclib sort of institution for a while. And what we find is people formulate their preference. And whatever your preference is, I think the utilization of ribociclib versus abema versus palbociclib would be based on patient tolerability and the patient that you're seeing in front of you. It would be based on the patient's age. You speak specifically about de novo. We tend to think of those as more responsive type of tumor versus ones that's progressing. So that's something else that we're thinking about. And I'm more likely to think of a palbociclib in that space if I'm thinking of if symptom and AEs is of a concern. But for most part, we select in our institution either ribociclib or abemaciclib in the first line setting.
And, I know you mentioned this about how do you think about who continues CDK beyond progression, and I'm curious how you've factored it in.
So the patients who've had really good response to CDK4/6 inhibitors in the first line setting, and we have some data, is likely to be the patient who would continue to have some response going forward. Again, molecular profile, while if this patient is developing like an RB1 mutation, which we generally associate with CDK4/6 resistance, I am not doing this going forward. If the patient has a targeted approach, a PI3 kinase mutation, ESR1 mutation, that will also influence my choice. Overall, looking at the EMBER-3 data for somebody like myself, who like to use abemaciclib up front, remember we don't have abemaciclib after abemaciclib data, then it makes it difficult for me to use that approach in the second line setting because we don't have data in that setting. So, that's one of the things I've been thinking about. So am I now forced to use ribociclib if it's approved in that setting, first line, so that I can utilize CDK4/6 continuation with abemaciclib in the second line? So that is the thing I'm thinking about. But definitely it depends on the patient's mutation, their benefit on CDK4/6 inhibitor, and also whether or not I have any concerns about whether I need to get either faster control of the disease, the rate of progression, do I need to go to chemotherapy first or not, would influence my choice in the second line. What about you?
I think it's very similar. I mean, I'll say I think, once someone progresses on first-line therapy, I do really make sure I get a genomic assay. I typically will just get a ctDNA blood draw because I'll get that result back in a quick enough manner to help me make a decision. And so, as you point out, I'm looking to see, do they have an ESR1 mutation? Do they have a PI3K pathway mutation? Do they have an RB mutation? Do they have a germline BRCA alteration? All these pieces we're trying to keep in our minds. But then you're right, I also judge how did they do on their prior therapy to make that decision. So, I think if someone doesn't have a targetable mutation, then I think those are patients where I debate, do I want to give them, for example, fulvestrant everolimus or fulvestrant abema, for example? Do I want to continue a CDK beyond progression? And so the people I've been generally continuing CDK beyond progression are usually the people who, as you were, very long duration benefit on upfront CDK, did not develop an RB mutation, do not have a targetable other pathway alteration, and don't have a ton of progression. So it's someone who maybe had a little bit of progression on their CDK, and I was kind of like, well, I wish I could continue it, and I want to just switch out the endocrine backbone. And those are the people that I've done as you do, switch the endocrine backbone and switch the CDK in those type of patients. But I think EMBER-3 calls that decision into question because, it does suggest that imlunestrant and abema seem to do very well irrespective of genomic alteration, and is a really seems like a well-tolerated option. Obviously not yet FDA approved at this time, but does make you wonder if we could expand that to a broader population. So that's why I think this is so complicated, that there really isn't a wrong or a right, but what is really critical is that we do get genomic data to know if they're a candidate for a PI3K pathway drug or a SERD or not. And I think sometimes, I've noticed that I'll see second opinions and sometimes they haven't had that done. And so I just want to make sure people do remember that it is really important to get that information to make a decision.
And also to repeat if you haven't seen an ESR1 mutation, because that shows up with over time. So if you did it first line or second line and you didn't see an ESR1 mutation, you should repeat on progression because it can show up later.
Yeah, well, that's a good point.
All right, so we'll go through this case. 61-year-old postmenopausal woman with a history of invasive carcinoma. She had a mammogram showing a 2.7 centimeter mass and some suspicious lymph nodes. She underwent lumpectomy, had chemotherapy, radiation, and was on adjuvant aromatase inhibitor. She also had a long-standing history of depression on SSRIs. 2 years later, she developed right hip pain. Bone scan showed a latic lesion. CT confirmed liver bone metastasis. Biopsy showed ER-positive disease, BRCA negative, normal liver exams. QTC was 585. Stuff to consider: what treatment would be the best option for this patient, which factors should be taken into consideration here in the first line setting for this patient, and also comorbidities. Sarah, how would you address this patient?
Yeah, no, this is a little tricky, right? Because this is someone who's recurred on an adjuvant AI and has visceral and bone metastases. So now I will say I think things have changed a little bit, because if someone's recurred on or within a year of endocrine therapy, I am getting genomic information to help me figure out what to do. We do have data, for example, from the Inavo 120 study, which did show that if we add inavolisib to fulvestrant and palbociclib in that first line setting for these patients who have demonstrated some upfront endocrine resistance and have a known PI3 kinase mutation, that in essence you doubled progression-free survival by adding inavolisib. And we just saw a press release that it actually improved overall survival. So really, I think that we can't forget that, because I used to not make sure I have genomic data before making a treatment decision in the first line because it didn't matter, but now it does. And so I think in this case, you would want to understand if the patient is a candidate for inavolisib, and so you would want to get genomic testing. Otherwise, if she's PI3K wild type, I think normally we would think about fulvestrant with a CDK4/6 inhibitor. Here, however, it sounds like she's on an SSRI and has a prolonged QTC. And so either she would need to switch her drugs up and see if you can get her QTC down if you wanted to use ribociclib, or I think you could choose a different CDK4/6 inhibitor. And so you could do something like fulvestrant to abemaciclib, for example, or even if you felt comfortable, fulvestrant palbociclib. So I think this is where your point about making sure you've looked at drug interactions and you've looked at the baseline QTC does really come into place, so that you're making a decision based off of that. And so don't want to start someone on ribo with their QTC that high. And in fact, I think you probably need to work on getting her QTC down anyway, and probably switching up her drugs to make that happen regardless.
What if it was a younger patient? We talked about some factors, comorbidity factors you spoke about. Bone-only disease, does that change your approach for CDK4/6 in the first line?
I will say if someone had a recurrence on or within a year of an AI that was bone only, I guess I would also wonder, do I really need to use inavolisib if they had a PI3 kinase mutation? Simply because of the toxicity. These drugs it's not easy to get triplets. And while, overall that study looks amazing with PFS and OS benefit, that's very striking. It was in a very tightly regulated population, which is probably not the average U.S. patient who has a A1C under 6. And, the drug can cause diarrhea, stomatitis, hyperglycemia. So all of those things we have to keep in mind. And so I think if someone had bone-only disease, I might maybe not use a PI3 kinase inhibitor up front, because you could always give it second line. So I think the bone-only can influence you a little bit there, where, if someone has got visceral disease, then I tend to be a bit more aggressive in the treatment decision.
Yeah. We don't really see brain metastasis in that population, but if they do have one, we rarely see it. Not don't really. We rarely see brain metastasis at that first line. But if somebody does have one, does it influence your approach for systemic therapy?
Yeah, as you pointed out, this would be super duper rare in a first line metastatic hormone receptor positive breast cancer patient to present with brain metastases. I did just see it with one of my fellows last month, and I was like, don't think this is normal. This is very unusual. But it did influence us because. We do have some data for CNS penetration with abemaciclib, with some clinical data suggesting that abemaciclib can induce responses in the CNS. So, if you're going to have to pick a CDK4/6 inhibitor in that upfront setting, you would probably want to pick one with known CNS penetration. And so I think abemaciclib certainly would make sense. Usually, though, if someone had a brain met, I would try to do upfront radiation and then move them on to the AI abema after that.
All right. So we'll move to module 3, and Dr. Delaney will take us from here.
So I think, we've done a nice job and I think covered a little bit of some of the classic toxicities that can arise with these medications in the metastatic setting. But I think this is a really nice overview where you can see some of the differences between palbociclib, ribociclib, and abemaciclib. And, as was noted, abemaciclib has the unique toxicity of having diarrhea as a side effect. And, usually it's low-grade diarrhea, but you can see up to 10% of patients having high-grade diarrhea. The other unique thing about abemaciclib is it is dosed continuously. So it's twice daily continuously, whereas both palbociclib and ribociclib are dosed intermittently, so 3 weeks on, 1 week off. And both palbociclib and ribociclib tend to have more in the way of neutropenia. So you see that, about 2/3 of patients will have high-grade neutropenia. And we see that about half of patients across all of these CDK4/6 inhibitors do end up requiring dose modification. With abemaciclib, the most common reason for dose modification is generally the GI side effects, whereas for palbociclib and ribociclib, it's generally the neutropenia. The other unique things to keep in mind that we've touched upon a little bit is that the ribociclib can cause elevation in transaminases. And interestingly, this is not really a dose-dependent toxicity. So even when they've looked at head-to-head starting doses being different, it wasn't that the rate of LFT abnormalities went down as you dose reduced. So it is important to watch that in patients getting ribociclib and monitor that and hold drug if they do get significant elevation of LFTs, and wait for it to get back to grade 1 or better before reinitiation. And I do dose modify when I restart the ribociclib in that setting. And then, as we noted, QTC prolongation is something to monitor with ribociclib. Usually you want to check it, baseline day 15 and cycle 2 day 1, and look for that prolongation of QTC. And if it's getting prolonged, then think about holding drug. Usually I find that patients have some medication that's messing with their QTC, and so it's really important to look through their medication list and see if there's something that you could potentially get rid of, or maybe substitute with a different drug to really bring that QTC down. So just, again, some unique things about these. And then when you think about dose modifying, with abemaciclib, you're going from 150 to 100, and then you can go even down to 50 twice a day. With ribociclib, if you're in the metastatic setting, you'd be starting at the 600 milligram dose, then you could go to 400 and 200. Whereas in the adjuvant setting, again, you're starting lower. You're starting at that 400 dose. So you only have one dose level to go down to dose modified, going from 400 to 200. And then with palbociclib, you can go from 125 to 100 to 75. So just to keep these dose levels in mind. I think what we've seen across all of these agents is they can cause some mild fatigue. And generally, we do see that toxicities tend to be a little bit worse in older patients compared to younger patients. It doesn't mean that older patients can't get these drugs. They do very well with them. But generally, some of the side effects can be a little bit more exacerbated in older patients. So, for example, with abemaciclib, you can see a little bit more in the way of diarrhea in your older patient. And with ribociclib and palbociclib. Sometimes you'll see a little bit more in the way of neutropenia. So it is just important, again, to monitor all these things in our older patients and be cautious. I think with all of these drugs, they are oral medications, and it's really important to have discussions with your patients about adherence and persistence with therapy, given what an incredible impact these drugs do have on outcome. I don't know, Gregor, if you have any tips and tricks that you use to help with keeping patients on treatment.
Yeah, so it's education. Every patient that I give, for example, abemaciclib, give a prescription for Imodium, and I do advise my patients to not wait to use the Imodium. At first, watery bowel movement, use it. And keep on using it. You can't, 8 per day is your max. Sometimes I do 2 after every bowel movement. And if you're still having a lot of diarrhea after that, let us know. Whole drug will advise you come back in. So advising your patients on how to manage the toxicity, but also letting them know when it is okay for you to reach back out to us has been very, very helpful for me in keeping my patients on drugs.
Oh, thank you. And are there any ways that you, as a group, are managing side effects that arise? Do you have any systematic way for monitoring what side effects people are having? Do you have a way to, have nurses help, or how do you guys handle this?
We are currently looking at tools to follow patients while they are out at home using virtual options. There's a company that we're looking at right now that has a sensor, for example, that can sense different vital signs changes, or a mobile app that we've presented some data on at ASCO, where patients can report their symptoms, and the app will prompt you once a week, how are you doing? Or you could go in and say, this is what's going on. And then it goes into the clinic. But for now, in my clinic, it's usually my pod, my nurse, my MA, my nurse practitioner that are following my patients. What about you guys?
Yeah, and we, thankfully it's nice to have a team approach with this. And so, in our team, we have a pharmacist who does a check-in with the patient shortly after beginning an oral therapy and make sure that, one, they're taking the right dose, that they're not having side effects. And I think that's been really helpful. They can reinforce, management and then answer any questions. And then patients generally are calling in if they're having any issues. And we have a nurse navigator as well as our nurse practitioners that help address these questions. So, it is important to make sure that patients are able to communicate, as you noted, in a rapid manner, because I think we want to make sure that we're dealing with side effects as they arise and we don't let them persist for too long and then they become more challenging than they should be. So, I think overall, this has been a really helpful discussion to me. I think I've learned a lot. I think we've been able to see what an important impact the CDK4/6 inhibitors have had in the early disease setting, now really being standard in both intermediate and high risk hormone receptor positive breast cancer, but then also in the metastatic setting where they've really changed the natural history of the disease. We're seeing survival that exceeds 5 years, which we've never seen prior to the introduction of CDK4/6 inhibitors, and now even seeing some benefit for continuation beyond progression. And then, as we pointed out, lots of choices in this metastatic setting. You can visit the website as shown here and complete and submit your post-test and evaluation for credit. You can also download the slides and practice aids and watch and replay this event over the next 24 hours and the online activity over the coming weeks. You can request a live meeting at your institution. Thank you so much, Gregory, for joining me today and for the wonderful discussion.
Thank you so very much. This was wonderful.
Welcome to our program on elevating
and sense different vital signs changes, or a mobile app that we've presented some data on at ASCO, where patients can report their symptoms, and the app will prompt you once a week, how are you doing? Or you could go in and say, this is what's going on, and then it goes into the clinic. But for now, in my clinic, it's usually my pod, my nurse, my MA, my nurse practitioner that are following my patients. What about you guys?
Yeah, and thankfully it's nice to have a team approach with this. And so, in our team, we have a pharmacist who does a check-in with the patient shortly after beginning an oral therapy and make sure that, one, they're taking the right dose, that they're not having side effects. And I think that's been really helpful. They can reinforce, management and then answer any questions. And then patients generally are calling in if they're having any issues. And we have a nurse navigator as well as our nurse practitioners that help address these questions. So, it is important to make sure that patients are able to communicate, as you noted, in a rapid manner, because I think we want to make sure that we're dealing with side effects as they arise and we don't let them persist for too long and then they become more challenging than they should be. So, I think overall, this has been a really helpful discussion to me. I think I've learned a lot. I think we've been able to see what an important impact the CDK4/6 inhibitors have had in the early disease setting, now really being standard in both intermediate and high risk hormone receptor positive breast cancer, but then also in the metastatic setting where they've really changed the natural history of the disease. We're seeing survival that exceeds 5 years, which we've never seen prior to the introduction of CDK4/6 inhibitors, and now even seeing some benefit for continuation beyond progression. And then, as we pointed out, lots of choices in this metastatic setting. You can visit the website as shown here and complete and submit your post-test and evaluation for credit. You can also download the slides and practice aids and watch and replay this event over the next 24 hours and the online activity over the coming weeks. You can request a live meeting at your institution. Thank you so much, Gregory, for joining me today and for the wonderful discussion.
Thank you so very much. This was wonderful.
Welcome to our program on elevating natural history of the disease. We're seeing survival that exceeds 5 years, which we've never seen prior to the introduction of CDK4/6 inhibitors, and now even seeing some benefit for continuation beyond progression. And then, as we pointed out, lots of choices in this metastatic setting. You can visit the website as shown here and complete and submit your post-test and evaluation for credit. You can also download the slides and practice aids and watch and replay this event over the next 24 hours and the online activity over the coming weeks. You can request a live meeting at your institution. Thank you so much, Gregory, for joining me today and for the wonderful discussion.
Thank you so very much. This was wonderful.